This week on Empowering Midlife Wellness, I'm talking about the most common and most annoying side effect from menopausal hormone therapy, which is bleeding. We'll talk about what causes it, most importantly, how to get it to stop so that you can continue getting all the benefits from your hormone therapy without any more bleeding. Hi friends, and welcome to this week's episode. If you're just joining me, I'm Dr. Susan. I'm a board-certified gynecologist and certified menopause practitioner dedicated to taking care of women in midlife, in perimenopause, menopause, and beyond. Women like me who want to feel great now and also build the healthiest elderly version of ourselves. So I made a video about this a couple of years ago, but I want to circle back to this question because it does come up quite a lot, and that is what to do if I'm having bleeding on menopausal hormone therapy. Well, the good news is that only happens to about 5% of patients who start on hormone therapy. Bad news is 5% is still a lot of people, so we want to address it. And talking about how great hormones are all the time is wonderful. And I'm a big proponent of menopausal hormone therapy, but like anything that works, everything that has multiple beneficial effects is also going to have a couple of side effects. And so this is the most common annoying side effect that we see with menopausal hormone therapy. So let's talk about why we get it and what we can do about it. And the most important thing I want to tell you is if you start bleeding in the first few months of starting on hormones, don't worry. It's fine. It's nothing to worry about. It's a big fat annoyance, really, really inconvenient, but very, very unlikely that anything's wrong. So with that in the front of mind, let's talk about why this happens and what we can do about it. Well, going back to what we remember about hormones from our reproductive years, very briefly, when we went through puberty, let's just pretend we had perfect cycles. I know most of us didn't, but if we had periods every 28 to 30 days, we were producing estradiol, progesterone, and testosterone. Now, a little side note, I'm not going to talk about testosterone today. It's a really important hormone. I love it. But in the context of bleeding, when we're on menopausal hormone therapy, it's not related to testosterone. So today we're going to be talking about just estradiol and progesterone because those are the two that can be involved in bleeding. Okay, back to when we were younger, starting at around age 12 on average, we started producing estradiol, and every month it would go up very high. Around the time we released an egg, it would peak, and then it would drop if we don't get pregnant, and that drop in estrogen is one of the things that would signal us to shed the lining and start on over again. So as estrogen comes up, the lining starts to grow, preparing the uterus for fertility, and then if we don't get pregnant, estrogen drops and the lining sheds, and on it goes. So that up and down of hormones is what caused us to have a period when we were ovulating. So keep that in the back of mind. Now, what about progesterone? Well, remember, we didn't make any until after ovulation, and then we'd make a bunch of progesterone. It's progestational. It helps support the embryo if we get pregnant. So if we get pregnant, both of those continue on. If we don't, the progesterone also drops. So there's an abrupt drop in estradiol and progesterone every month. That drop causes us to have a period, and everything's usually pretty okay, right? Well, let's just skip ahead now to menopause. Now, I am going to talk about perimenopause and abnormal bleeding as well, but let me first focus on postmenopausal patients, that is, women who have gone through the menopause transition, women like me who essentially are producing no estradiol or very, very little, no progesterone because we're not ovulating anymore. Now, you've had no estradiol or progesterone in your system for some period of time. Maybe it's a few months or maybe it's a few years. And then we give you menopausal hormone therapy, which is wonderful for all of the reasons that we've discussed. Lots and lots of health benefits, not only feeling great, but reduction in a bunch of chronic diseases. Well, our body is seeing these hormones that it hasn't seen in a little while. And one of the organs that responds to that the most is the uterus, if we still have one. So all of our lives, the uterus has responded appropriately to increases in hormones. So when it sees a little more estradiol and progesterone coming along, it may pick up the signal to grow some lining. Now, interestingly, estradiol has the effect of growing lining in the uterus. Remember, it grew the lining as we approached ovulation back in the old days. And progesterone actually has an opposite effect. It causes the lining to shrink in a simple sense. So if estradiol and progesterone are absolutely perfectly balanced in our system in a menopausal hormone therapy protocol, we're not going to bleed at all. And that's why most patients don't bleed. We're taking hormones continuously. There's no up and down, so there's nothing to trigger us to bleed, and we won't bleed. Now, in 5% of patients, for whatever reason, if they're prescribed the perfect dose by the most careful provider, this happens in our practice and all practices, a small percentage of patients are going to have more of that estrogen effect at the level of the uterus. So they're going to grow some lining, and for reasons that are just because humans are all different, they're going to experience less of that progesterone effect, so there won't be that balancing effect on the uterine lining, and we'll see more growth than the opposite. Now in that patient, they're going to grow some lining, which will eventually come out. So if we've got uterine lining, it will come out. So if we start on hormone therapy and the estrogen causes some lining to grow, at some point, and it's usually a month or 2 or 3 months into the treatment, typically we start spotting. It's not usually like a full period. It's more often just this annoying bleeding a little bit at a time, and it can go on and on and on, which is super annoying and very scary. Remember what I told you in the beginning, it's extremely unlikely to be uterine cancer or precancer or anything like that. It's almost always just a function of the uterus responding to these new hormones that we've seen all of our life, but new in the context of we've had a little break from them for a while. So typically, bleeding is spotting that goes on, it doesn't stop, it never completely goes away, and really frustrating because who wants to have that? I mean, the best thing about menopause, or one of them, is that we don't have to have periods anymore, and I absolutely love that about menopause myself. I don't know a patient who really misses having a period. It's something that is a blessing to be rid of, so in no way are we saying that that's okay. We want that to go away. So how do we work with a patient who presents this way? Let's say you came in, you were menopausal, you had essentially no estrogen or progesterone. We replaced them appropriately. Now it's 2 months later and you've been spotting for 2 weeks. Well, the first thing I'm going to do is talk to the patient and reassure her. Say, hey, don't panic. I know you've been on Google and you're worried. Everything's going to be fine. That's number one. Number two is we need to get it to stop. So how do we do that? Well, we're recognizing that the patient's getting, in effect, too much estrogen and not enough progesterone at the level of the uterus. And that's a very simple way of saying things. The first thing to do is to address the progesterone. So simple questions like, are you taking it? It doesn't work unless you put it in your mouth. So we give progesterone in oral form, because it is not absorbed well through the skin. So if that patient was using a progesterone cream and she had not taken my advice the first time, I would remind her this is exactly why we don't want to use progesterone cream. We don't get enough progesterone in the cream to prevent the uterus from growing lining and ultimately prevent uterine cancer. So taking it by mouth. All right, are you taking it every day? Are you taking it with food? Because micronized progesterone is in an oil base. It absorbs better with food. It does not absorb well on an empty stomach. Now, taking it at bedtime is important because it makes you sleepy. So for most patients, you don't have to take it with dinner, but if you've gone more than 2 hours without eating, it's not going to be absorbed as well. So this is quite common these days. Many people are eating their last meal 3 or 4 hours before bedtime because it's great for their blood sugar. So we'll look at those kind of things and just ask the patient to take it a little earlier, or maybe have it with a little milk or something, just something that will help it to absorb. So are you taking it, number one? Are you taking it at the right time? And that is within 2 hours of food. And if you're doing both of those things already, we can increase the dose. So progesterone, we had buckets of it when we were pregnant. It's a happy, healthy hormone. It's fine to take a lot of progesterone. The only side effect from doing that is it can make you really sleepy. So we're balancing that wonderful side effect because it helps with insomnia. We don't want you to be too sleepy. So, for example, 100 milligrams of micronized progesterone is the standard amount that's recognized to help keep the uterine lining pretty stable. But many patients, including me, take 200 milligrams. Some patients even take more. The other thing about progesterone, other than it being safe to take more, is Everybody absorbs things differently, right? This is something that we take by mouth because the transdermal is not absorbed well. And so we're going through the stomach, we're going through the liver. It's varying in amount how much actually gets to the uterus. So some patients need 200 milligrams and they get the same amount in their uterus as a different patient who takes 100 milligrams. So just to say, either dose is fine. We give you as much as you need. So we would make sure you're taking it, make sure you're taking it at the right time within 2 hours of food, and then make sure you're taking enough. So we would give you some more if you're still bleeding. Now, in the vast majority of patients, that will cause the bleeding to stop within 2 weeks. Problem solved. Now, we wouldn't decrease the estrogen generally because estrogen's really, really healthy. We love it, and we're just assuming we've given you the appropriate amount already. So generally, we're playing with increasing the progesterone. Now, if that doesn't work, decreasing the estrogen might be something to consider, but you get the idea. We're working with that balance to get it exactly right for you. Now, we wouldn't want you to have hot flashes, night sweats, and other symptoms as a result of decreasing the estrogen. So that's why you need a provider who really knows how to make this very personalized for you, recognizing that everybody's different. All right, so now let's just assume we got the bleeding to stop. Problem solved. If we don't get it to stop, and I would wait a couple of weeks, then we want to go a little further and do some investigation. Again, not because we're worried about it being cancer, mostly because we just want it to go away so you can carry on with your life and stop being bothered by this because it's super annoying. The first step is to do an ultrasound. Now, a transvaginal ultrasound, many of us have had one before when we were pregnant. A small probe is put inside the vagina and it can actually measure how much lining you have grown. There's a standard, and we want to have less than 5 millimeters thickness of lining. That's the inside of the uterine cavity. I've said before, I often say it's like a hamburger, and the meat would be the lining. The muscle of the uterus would be the bun in that analogy. So if you imagine we're measuring the thickness of the meat. Now the thickness should be less than 5 millimeters. If it's less than 5 millimeters, we pretty much know you don't have uterine cancer. There have been some very good studies showing that uterine lining less than 5 millimeters is essentially never uterine cancer. So we've just kind of taken that off the list of things to worry about. On the other hand, if it's greater than 5 millimeters, by no means does it mean you have uterine cancer. It just means that we need to do a little more evaluation. Most likely it's benign uterine lining that's just growing because you're very sensitive to estrogen, or it could be something else like a little benign polyp, a little benign fibroid. There's a lot of other things it could be before your mind darts immediately to cancer. But whatever it is, we want to get it to stop. All right, so if it's less than 5 millimeters, we know everything's fine and we're comfortable just to wait a little bit longer and work with balancing the hormones to see if we can get it to stop. If it's more than 5 millimeters or 5 or more, we would offer the patient to actually get a little sample of tissue and make sure that it's benign, again, to put her mind at rest. Now, I have had what's called an endometrial biopsy. That's the procedure where we get a little bit of tissue. It's not fun, I'll tell you the truth. I remember my doctor who did it when I was an infertility patient was a man, and he was great, and he said, it's just going to hurt a little bit. Well, he was wrong. It hurt quite a bit. Very manageable, but I think it's good to be prepared. A tiny little catheter is put inside the uterine cavity while you're in the office, and we wiggle it around just to dislodge whatever lining's there, and then it's sucked up into the little tiny catheter, and we have a small specimen that we can send to the pathologist. They're going to come back and tell us it's benign, and then we can all sleep at night. Now, remember in that scenario, there was more than 5 millimeters of lining there. We didn't remove it all with the biopsy. We just got a tiny little piece. So the problem is still there. In other words, you're still bleeding, but we've ruled out cancer, which is great. So the next step is, again, to get it to stop. If you're still bleeding and we've tried all the other things, we would next put a little camera in the uterine cavity. Now, this can be done in the office, but it would be uncomfortable, similar to the biopsy. Some doctors have the capability to do it in office or in an outpatient surgery setting with some sedation. Tiny little cameras placed into the uterine cavity, and then we can see what's going on. Is it a polyp? Is it just thick lining? Is there anything else that looks suspicious? And then whatever it is can be removed at the same time while you're undergoing that procedure. Again, at the end of that, then the problem, at least in the short term, is solved. Now, remember, whatever caused it to grow could come back if we haven't addressed the root cause, but for now, we're starting again with a clean slate. And for that particular patient, let's just say everything comes back as normal and benign, it was just related to the hormones, we would start on a little bit more progesterone, maybe a little less estrogen, depending on what her levels were, make sure she's taking it at the right time, all of those things. Now, there's a very, very small group of patients who continue bleeding after we've done all of those things. Now, that's a patient that we might consider a few really unusual things that we don't offer to everybody. But one of the easiest is that could be a really good candidate for having a progestin-containing IUD, intrauterine device. So IUDs, of course, are used for pregnancy prevention, but the ones that are coated in progestin, which is a synthetic type of progesterone, do wonders for preventing the uterine lining from growing. So in patients who are using it for birth control, they often are thrilled that their period stops or becomes very, very light. But in menopausal patients, not only does it provide protection to the uterus, but it makes sure we don't bleed. So that could be an option for a certain patient. Very rarely would we ever tell a patient not to take hormone therapy because of this. So the reason that we don't want to tell you not to take it is because there are so many health benefits. So it's really important that we continue working on this until it's gone. I have had patients who have come from other providers who were told, you have to stop taking hormones because of the bleeding. And I would absolutely disagree with that. We really want to find a way to allow you to be on estradiol for all of its health protective benefits without bleeding. And I promise you, I don't have a single patient who we haven't been able to find a solution for. It just might take a little bit of work and time. So you can find a solution. Okay, so I'm going to move on and talk a little bit about perimenopause, because frequently perimenopause, especially if we're getting towards the end of it, where maybe we've started skipping periods, we've presented to our provider having hot flashes, night sweats, low estrogen symptoms, it would be appropriate in that patient to start her on estradiol when she's not completely menopausal yet. So I would do that, and it would be a great idea to do so because those symptoms are no joke, and we want to make sure the patient's protected. Bones, heart, brain, all of the things, right? So remember, going back to the traditional diagnosis of menopause, and we need a new one, that menopause is the day that comes exactly a year after your last period. There's a lot of things wrong with that. For example, a lot of patients don't have a period. A lot of patients are completely hormone-free well before a year. But the point being, you might come in and you haven't had a period for 3 months, and we would start you on estrogen, and great. So now you're getting some estrogen in the background. Well, all of a sudden, you release an egg again because you're not menopausal yet. You're still perimenopausal. Now, remember, when you release an egg, your estrogen shoots up. So you've got the estrogen we're giving you, and now you've got your own estrogen that goes up, and then it drops. You're going to bleed. And so patients who are perimenopausal, who are started on menopausal hormone therapy, very appropriate, should always be told that they may continue to have periods. If you're still within that first year, we don't know if you're going to have another period or not. But I wouldn't tell you not to take hormone therapy during that time. I would just tell you, hey, you're going to have some irregular periods perhaps, and this isn't going to make it stop, but it'll make the symptoms go away. So that patient would present a little differently. Now, remember, we talked about bleeding on menopausal hormone therapy for truly menopausal patients like me almost always is spotting. It's just a little bit of that lining sloughing off a little bit at a time. When we're perimenopausal, often we'll just have a full period. If you have a full period, like 3 to 7 days of bleeding that requires protection, that's probably not from the hormone therapy. It's probably because of your own hormone fluctuation in the background. I've had patients that have literally gone a year and all of a sudden they ovulate again. When we're in those younger years of menopause, sometimes we're diagnosed as being postmenopausal and our ovaries have a different idea. They'll release another egg, up goes our hormones, and then as the subsequent hormones drop, we bleed again. So in that early stage, don't be surprised or alarmed or scared if you bleed again. Sometimes our ovaries just are not quite done. So that's a little word on perimenopausal hormone therapy because it's very erratic. Perimenopause, we often say, is defined by being all over the place. It's a roller coaster of hormones. And so whatever we give you in the background, it's going to be affected by what your own body could still produce. Hopefully that makes sense. So I hope you learned something today. Most importantly, if you are bleeding on menopausal hormone therapy, don't be scared. Everything's fine. But it's annoying and we want it to stop. Most important is you need to be taken care of by somebody who knows how to customize this for you so that we can get a solution that actually works for you. Might be different than what works for me or for your neighbor. All of this can be customized so that you can enjoy the benefit of menopausal hormone therapy without any of these annoying side effects. So we do see patients in Houston, both in person and remotely. We see patients from all over the world. If you live in Texas or California, we're licensed in those states and can perform the full degree of medical care, including prescribing. Otherwise, we see patients through our coaching and education platform, can also tell you all the things you need to know about how to reach your full aliveness in this amazing time of life. So please don't forget to subscribe, share it with your friends, and I can't wait to see you next week.